Imagine you are standing in the basement of this insanely dense, incredibly old historic building. You've got century-old plumbing, massive electrical conduits, and these really delicate communication wires.
Right, just crisscrossing everywhere.
Exactly. All crammed into this one narrow, tiny utility closet. And right in the middle of it all is a load-bearing pillar.
Oh, man. Yeah, you can't exactly just swing a sledgehammer in there.
You really can't. You risk collapsing the entire structure or knocking out power to the whole block. And, when we talk about human anatomy, the pelvis is exactly that historic basement. And today, we are going on a deep dive into what might be the most high-stakes, precarious 12 to 15 centimeters in the human body, the rectum.
It is just a phenomenal way to look at it because when we talk about surgical oncology and pelvic anatomy, the history of how we treat diseases in this area is, well, it's basically a history of demolition.
Wow, demolition.
Yeah, for a long time, the surgical approach was essentially to dynamite that load-bearing pillar just to get the disease out. The cancer might be gone, sure, but the collateral damage.
It must have been awful.
It was absolutely devastating for the patient. The surrounding wiring gets completely destroyed.
Which, that means losing fundamental, highly personal bodily functions.
Yeah.
So today, our mission for this deep dive is to explore how medical thinking evolved, right? From those blunt, life-altering excisions to, incredibly elegant precision.
And eventually to the revolutionary idea of maybe not doing surgery at all.
Right, which is just wild to think about. But before we get there, I want to make sure you, the listener, and I are picturing this architecture perfectly, because it's not just a simple biological tube, is it? The sources practically call it a border town.
It quite literally is a border town. In the human body, there's this distinct embryological watershed in the anal canal. It's called the pectinate line, or the dentate line.
Okay, dentate line.
Right. And to understand why it's a border town, you have to imagine how a human fetus develops. The upper part of this tract grows downward from the inside of the body. That's tissue from the hindgut. But the lower part is formed by tissue growing inward from the outside, from the proctodeum, and they just meet in the middle at this pectinate line.
So it's literally two completely different construction projects, just like meeting in the dark.
Exactly. And that origin story dictates everything about how the area functions as an adult. The blood supply, the nerves, the lymph nodes.
They follow different rules.
Entirely different highways depending on which side of the border you're on. For example, if you have an infection or cancer above that line, the lymphatic drainage travels up deep into the abdomen.
Wait, and if it's below?
Below the line, it drains down to the superficial nodes in the groin. So if you are a surgeon tracking where a cancer might have spread, you absolutely have to know which side of that border the tumor started on.
That is incredibly specific. And the geography of the rectum itself, especially above that line, is mapped out by this 6-12-15 rule.
Yeah.
Which, if I'm visualizing this right, means the whole organ is only 12 to 15 centimeters long total.
Yep, that's correct.
So the low rectum is the first 6 centimeters from the outside. The mid-rectum is 6 to 12. And the upper is 12 to 15, right up to where it meets the colon.
That's spot on. And inside that 15-centimeter tube, it's not a straight drop. You have these structural ledges called Houston's valves.
Houston's valves. What do they do?
Well, there are usually 3 of them, and their job is to support the weight of fecal matter so it isn't constantly pressing down on the sphincter.
Oh, that makes a ton of sense.
Yeah, and interestingly, unlike the rest of the gastrointestinal tract, these valves actually lack a specific layer of muscle called the muscularis mucosae.
Huh. But, the part that really stops me in my tracks about this, the part that makes this the most terrifying utility closet in the body, is the wiring wrapped around the outside of it.
The nerves.
The nerves. It is so precarious.
The nerve plexuses in the pelvis are profoundly complex. You have sympathetic nerves descending from the lumbar spine, L1 to L3.
And what do those govern?
In men, they govern the mechanics of ejaculation. Then you have parasympathetic nerves coming from the sacral spine, S2 to S4, which govern erection.
Wow.
And both sets of those nerves are deeply involved in bladder function and continence for everyone.
So if a surgeon is in there working in this dark, bloody cavity, and their scalpel is off by a single millimeter.
Exactly 1 millimeter.
The patient wakes up, cured of cancer, maybe, but permanently unable to urinate normally or ever have sexual function again.
And that was the grim reality for decades. Those nerves are plastered against the side walls of the pelvis, right next to the rectum.
Which brings up one of my absolute favorite anatomical concepts in our deep dive today, the mesorectum.
Ah, yes, the protective layer.
Right. To protect all this, the body wrapped the rectum in a fatty, fibrous envelope. I like to picture it as highly specialized bubble wrap.
Bubble wrap, I love that.
Yeah, it's bubble wrap
Yeah.
protecting a fragile, explosive package from all those delicate wires.
That analogy is perfect.
Right.
And it is actually the key to one of the greatest leaps in surgical history. Back in 1982, a British surgeon named Richard Heald introduced a concept that became known as the Holy Plane.
The Holy Plane. I mean, it sounds mythological.
In the surgical world, it really is revered. Before Heald, surgeons would often use blunt dissection,
Wait, what does blunt dissection mean?
literally using their hands to physically tear the rectum free from the pelvis.
Oh, God.
Right. And when you do that, you rip the bubble wrap, you tear into the mesorectum, leaving bits of fat and lymph nodes behind.
And if there's cancer in that fat?
Exactly. There were microscopic cancer cells in there. You just spilled them all over the pelvic cavity.
Which completely explains why historic recurrence rates were so terrifyingly high. Nearly 1 in 4 patients had the cancer grow back in the pelvis.
Exactly. But Heald realized that if a surgeon performs a meticulous sharp dissection perfectly outside the fascial envelope,
Like never breaching the bubble wrap.
exactly, never breaching it, they can remove the rectum and all its surrounding lymph nodes as one completely intact package. This technique is called total mesorectal excision, or TME.
And what was the outcome of that?
The local recurrence rate plummeted. It dropped from 25% down to under 10%.
Just by respecting that boundary.
Yes, just by recognizing and respecting the perfect architectural boundary of the Holy Plane. It remains the defining principle of modern rectal cancer surgery.
Okay, so we've established the flawless, precarious architecture of the pelvis,
Yeah.
right? And how surgeons navigate it. But I really want to pivot and look at what happens when that architecture fails.
Right, when things break down.
Yeah, and medically, it seems we can divide this into mechanical failure and cellular failure. Let's start with mechanical. Prolapse.
Yeah.
Basically, the load-bearing walls just give out.
Right. Prolapse is essentially a structural collapse. You can have mucosal prolapse where just the inner wallpaper of the rectum slips down, creating these radial folds.
Okay, inner wallpaper slipping.
Or you can have full thickness prolapse, known as proscedentia. That's where the entire muscular wall of the tube telescopes in on itself and protrudes entirely outside the body.
Oh, wow. And the demographics for who gets this are fascinating to me. On one hand, you have multiparous elderly women, women who have given birth multiple times.
Which makes total physical sense.
Totally. Years of childbearing, aging tissues, a weakened pelvic floor. Eventually, the suspension cables just snap. But then there's this totally unexpected group, children with cystic fibrosis.
Yes, that often surprises people.
I mean, how does a respiratory disease cause a rectal prolapse?
It comes down to basic biomechanics. Children with cystic fibrosis suffer from severe chronic coughing. Every time they cough, the diaphragm violently pushes down, acting like a piston.
Just hammering down.
Exactly. This massively spikes the pressure inside the abdomen. And when you combine that relentless downward piston action with the malnutrition and chronic diarrhea often associated with CF,
The pelvic floor just can't take it.
it simply gets overwhelmed. The rectum is forced out under pressure.
So the mechanism is completely different, right? A sudden pressure spike versus decades of wear and tear. But the mechanical failure is exactly the same. I'd imagine you fix those differently, though.
You do. In children, it's usually treated conservatively by managing the underlying condition. But in adults, surgeons have to step in.
So
Well, if the patient is healthy enough, they go in through the abdomen, pull the rectum back up like a puppet on a string, and anchor it to the tailbone with a piece of mesh, like a puppet on a string.
wow. And if they aren't healthy enough?
If the patient is too old or frail for major abdominal surgery, they do a perineal approach, like the Altemeyer procedure, where they essentially operate from the outside, pulling the prolapsed section out and trimming it off.
Okay, that makes physical sense.
Yeah.
But before we move on to cellular failure, I have to ask you about something that absolutely baffled me when I was reading the sources.
Let me guess.
Solitary rectal ulcer syndrome, SRUS.
Ah, yes. The naming convention.
It is entirely absurd. The medical texts literally say solitary rectal ulcer syndrome might involve multiple ulcers, it might have no ulcers at all, or it could present as a polyp.
Yeah, it's pretty contradictory.
Why on earth do they call it a solitary ulcer if it can be multiple or literally not an ulcer at all?
It is a legendary misnomer, and believe me, it frustrates medical students to no end. The key to understanding SRUS isn't looking for an ulcer at all.
Then what is it?
Is understanding the mechanism. It is fundamentally a problem of hidden internal prolapse and chronic straining. The wall of the rectum keeps getting pushed down into the anal canal, traumatizing the tissue over and over again.
So it's like constantly biting the inside of your cheek.
Precisely. And the body reacts to that relentless physical battering by desperately trying to armor the area.
Okay, armor the area. How?
If you look at this tissue under a microscope, the absolute giveaway, the pathognomonic sign, is something called fibromuscular obliteration of the lamina propria.
Okay, we need to translate that. Fibromuscular obliteration.
Huh. Right. The delicate, spongy connective tissue that normally lines the rectum gets completely wiped out. It gets replaced by tough, fibrous muscle and scar tissue.
Oh, wow.
The body is essentially turning the delicate inner lining into tough shoe leather just to survive the mechanical stress. It's a structural, physical trauma masquerading as a mucosal ulcer.
Turning delicate tissue into shoe leather. That is such a brilliant way to picture it. Okay, so that's mechanical trauma, the structure physically collapsing. But what happens when the structure is fine, but the cells themselves rebel?
That brings us to cellular failure, rectal cancer.
Right. And the sources say this is a huge issue.
It is. Rectal carcinoma makes up roughly 30% of all colorectal cancers, and it usually announces itself with two cardinal symptoms: bleeding, specifically bright red blood per rectum, and tenesmus.
Tenesmus. That's one of those words that sounds relatively benign until you know what it actually feels like.
It is incredibly distressing. Tenesmus is the persistent, uncomfortable feeling of incomplete evacuation.
Even when there's nothing there.
Exactly. Even when the rectum is completely empty, the physical bulk of the tumor presses against the highly sensitive stretch receptors in the wall.
Oh, so it's tricking the body.
Yes, it tricks the nervous system into a phantom limb type scenario, making the patient feel an unrelenting urge to go to the bathroom.
That sounds awful. And when a patient presents with those symptoms, the diagnostic protocol is ironclad, right?
Mm-hmm.
The digital rectal exam, or DRE, is completely non-negotiable.
It is the absolute foundation of surgical oncology. We have incredible imaging technology today, but a surgeon's gloved finger can tell them things a machine simply cannot feel.
Really? Like what?
Well, during a DRE, the surgeon is mentally mapping out a specific set of physical criteria. We use the acronym DMOF.
Okay, DMOFs. Let's walk through what the surgeon is actually feeling for in that dark utility closet. DEMOFS. Let's start with D.
D is for distance from the anal surge. Exactly how many centimeters up is the tumor? E is extent. Is it a small lump, or is it wrapping around the entire circumference of the tube like a ring?
Got it. M is mobility, right?
Right. If you push the tumor with your finger, does it slide around freely? Then O is orientation. Is it on the front wall near the prostate or vagina, or on the back wall near the tailbone?
And finally, F, fixity. This is kind of the moment of truth for the surgeon, isn't it?
It really is. Fixity asks, is this tumor tethered down? When the surgeon presses it, does it feel like a loose marble under a blanket, or does it feel like it's cemented directly into the structural walls of the pelvis?
Oh, man. And if it's fixed?
If it's fixed, it means the cancer has likely broken through the rectal wall and invaded the surrounding organs or the sphincter muscle itself.
Which means the surgery just went from a standard extraction to a massive, highly dangerous architectural reconstruction.
Exactly. Once the finger is mapped to the terrain, they bring in the technology. The gold standard for staging this locally is the high-resolution MRI.
And the MRI provides the definitive blueprint. The radiologists report their findings using another string of letters, right? TNCRMEMVI.
Yes. T tells us the depth of the tumor. N tells us if the lymph nodes are enlarged. But those last two, CRM and EMVI, are where the life or death surgical decisions are made.
Let's break those down. Starting with CRM, the circumferential resection margin. This goes right back to our bubble wrap analogy from earlier.
Yes, it does.
The CRM is the physical distance between the deepest edge of the tumor and the outer edge of the mesorectal fascia, the bubble wrap.
Exactly. The surgeon needs to know how close is the bomb to the edge of the protective casing.
And the cutoffs the sources mentioned is terrifyingly small. If the tumor is within 1 millimeter of that fascial edge, the margin is considered involved.
1 millimeter.
Like, to go back to our historic building analogy, if you are dynamiting a pillar and the explosives are within 1 millimeter of the main electrical conduit, the perimeter is breached.
That is the exact clinical reality. If the margin is threatened, the risk of the surgeon cutting through the tumor and leaving microscopic cancer cells behind in the pelvis skyrockets. The surgery alone will not be enough.
Wow. And then there's EMVI, extramural vascular invasion.
Right. EMVI means the radiologist can physically see the tumor cells breaking out of the rectum and invading the blood vessels just outside the wall.
That sounds bad.
It is an independent, very serious prognostic factor. Why? Because the cancer has just found an on-ramp to the systemic highway.
It can travel.
Exactly.
Yeah.
It's no longer just a local pelvic problem. It has the means to travel to the liver or the lungs.
So the surgeon has the MRI, they know the CRM, they know the EMVI, and they know the fixity. Now they have to decide how to operate. And historically, the main option was pretty brutal.
Yes, back in 1908, a surgeon named Ernest Miles pioneered the APR, the abdominoperineal resection.
And that was a big deal at the time, right?
The APR was a monumental achievement because it saved lives, but the cost was immense.
Yeah.
To get the cancer out, Miles determined you couldn't just take the rectum, you had to take the entire muscular floor of the pelvis.
Everything.
Everything. The rectum, the anal canal, the sphincter complex, all removed. The patient was left with a permanent colostomy, meaning their bowel was routed out through their abdomen into a bag for the rest of their lives.
Which means they survived, but their relationship with their own body was forever altered.
Absolutely, which is why the holy grail for a modern surgeon is to avoid an APR whenever biologically possible. They want to perform a LAR, a low anterior resection.
The LAR, that's the sphincter-preserving one, right?
Yes. You remove the cancerous section of the rectum, staying perfectly within that holy plane, but you leave the sphincter muscles intact. Then you pull the healthy colon down and reconnect the plumbing. The patient retains normal bodily functions.
Okay, so we've perfected the mechanical extraction. We know how to navigate the utility closet, preserve the wiring, respect the holy plane, and save the sphincter.
Right.
But this is where the story of modern oncology takes a massive, counterintuitive turn, because we are entering an era where the pinnacle of surgical thinking isn't asking, how do we do the best surgery?
Right. The question is, what if the best surgery is no surgery at all?
Which is mind-blowing.
Less is more. And this paradigm shift began with neoadjuvant therapy. Instead of doing surgery first and giving chemotherapy later to mop up the remaining cells, oncologists started giving the chemo and radiation before the scalpel ever touched the patient.
To shrink it down.
Exactly. The goal was to shrink the tumor, pull it away from that dangerous 1mm CRM border, and make the operation safer.
But recently, things have gotten even more aggressive, right, with TNT, total neoadjuvant therapy.
Yes, TNT.
This is where you give the patient all their systemic chemotherapy and all their pelvic radiation up front. Clinical trials have proven this massively increases the chances of shrinking the tumor. But from a purely mechanical standpoint,
Yeah.
if you hit this incredibly delicate, heavily wired pelvis with massive doses of radiation, doesn't that just turn the tissue to fibrotic scar? Doesn't it make the eventual surgery a complete nightmare?
It absolutely does. Operating in a radiated pelvis is notoriously difficult. The tissue planes become stiff, the anatomy gets distorted, and finding that perfect holy plane is infinitely harder.
Then why do it?
Well, what's fascinating is the twist. What if TNT works so well that you don't actually need to brave that nightmare surgery?
Wait, the tumor just vanishes, like completely.
In a significant percentage of patients, yes, they achieve what we call a complete clinical response. The tumor essentially melts away under the barrage of chemo and radiation, leaving nothing but a flat white scar on the rectal wall.
That is incredible.
And this observation led to one of the most controversial and ultimately brilliant protocols in modern medicine. It was pioneered by a Brazilian surgeon named Angelita Habergama.
The watch and wait protocol.
Exactly. Dr. Habergama posed a radical question to the surgical community. If there is no detectable tumor left after TNT, why are we subjecting this patient to a massive, life-altering total mesorectal excision?
Right. Why risk their sexual function, their bladder control, and a potential colostomy bag to remove an organ that no longer has cancer in it?
Exactly. But that is incredibly bold, to look at a patient who came to you with rectal cancer and say, we aren't going to cut it out.
I can imagine surgeons didn't love that at first.
Oh, it required a complete rewiring of surgical dogma. Surgeons are trained to operate. Not operating feels inherently unsafe to them.
Sure. So what do you do instead? Just hope for the best.
No, Habergama argued that you replace the surgery with the strictest surveillance program imaginable. The patient undergoes frequent, highly detailed MRIs and regular endoscopies to watch that scar.
Oh, I see. So you keep a super close eye on it.
Exactly.
Yeah.
If the tumor ever starts to regrow, you immediately perform the TME as a salvage operation. But if it doesn't, the patient keeps their organ, their quality of life is perfectly preserved.
And the data supports her, which is the best part. Patients who achieve that complete response and enter watch and wait have incredible survival rates without the morbidity of surgery.
They really do.
But if you thought melting a tumor with radiation was wild, we have to talk about a recent breakthrough from our sources that sounds like actual science fiction. A targeted therapy drug called dostarlimab.
This is truly a miracle of modern oncology, though we must be clear it applies to a very specific, genetically distinct subset of patients.
Right. We don't want to overstate it for everyone. It's for patients whose tumors have a specific genetic profile known as MSIH, or mismatch repair deficient.
Yes. Basically, these are tumors that have a critical defect in how they repair their own DNA.
And when oncologists gave these specific patients this immunotherapy drug, the results were almost impossible to believe.
100% complete response rate.
100%.
Yeah.
Every single patient in that clinical trial cohort saw their locally advanced rectal tumor completely disappear.
It's astonishing.
No radiation, no toxic chemotherapy, no surgery. Just a drug that unmasked the cancer so the patient's own immune system could hunt it down and eradicate it.
It is unprecedented in solid tumor oncology. Usually in cancer research, we celebrate a new drug if it gives a 15 or 20% improvement in survival.
Right.
To see a 100% complete response means that for this specific genetic subset, the disease was entirely wiped out mechanically and cellularly. It vanishes.
It vanishes. So let's step back for a second and look at the sheer scale of the journey we've just taken you, the listener, on today.
Okay.
We started in the cramped, high-stakes utility closet of the pelvis.
We explore the embryological border town of the pectinate line, the sympathetic wiring, and the biological bubble wrap of the mesorectum.
Yeah, and we saw how that delicate anatomy can suffer from the mechanical collapse of prolapse, or the desperate shoe-leather scarring of solitary rectal ulcer syndrome.
And we track the evolution of treating cellular failure.
Right, how surgeons moved from the blunt devastation of the permanent colostomy back in 1908 to the elegant, margin-sparing precision of Richard Heald's Holy Plane. We learned how to map the tumor with a finger and an MRI, and how to defuse the bomb without cutting the wrong wire.
And finally, we arrived at the current frontier. The realization that the absolute pinnacle of surgical thinking isn't just about inventing bigger, bolder ways to cut.
Sometimes true mastery is having a deep enough biological understanding and the profound restraint to know when to put the scalpel down.
Very well said.
Which leaves us with a pretty profound thought to mull over as we wrap up this deep dive. We spent all this time talking about the structural perfection of the Holy Plane and the incredible technical skill it takes to navigate it.
Yes.
But with immunotherapies completely melting away tumors and protocols like watch and wait proving that leaving well enough alone can save lives,
Yeah.
are we fast approaching a future where that mechanical Holy Plane is left entirely undisturbed? Will we look back in 50 years and see the scalpel as a barbaric relic of the past for rectal cancer? It really makes you wonder if the best way to save the control room is to never open the door in the first place.